Hello and welcome to Canvas, the Niger-Delta Roundtable, where I discuss the future of our region, humongously blessed with hydrocarbon resources. And every week, we give some time to reflecting on topics relevant to the development of the Niger-Delta and her people. This episode is no different, as I'm here to focus once again on how to take the region and our people to a more promising future. Now, this podcast is sponsored by the operator of the NNPC, Renaissance Total Energies Ajib joint venture, Renaissance Africa Energy Company Limited, headquartered here in Port Harcourt. Thank you for joining. I'm Adedayo Ilushakin. The topic for this episode is blood, sweat, and cells. June 19 is World Sickle Cell Day, and this year's theme is transforming care and strengthening communities. Sickle cell isn't just a medical condition, it's a lived experience. It's the pain that doesn't show up on scans, the stigma that hides in silence, and the strength that powers through it all. In this episode, we're diving into the blood, literally, to some degree, to understand what sickle cell disease is, why it matters, and how care is evolving from hospital beds to community hearts. We'll hear from an expert on the subject, an advocate who fights for better policies and deeper compassion. So whether you're tuning in from a clinic, a classroom, or your couch, welcome. You're part of the community we're strengthening today. A reminder, this episode's topic on Canvas is blood, sweat, and cells. And my guest is Dr. Linda Anucha Dublin-Green. Dr. Dublin-Green, hi, welcome to the podcast once again.
Thank you so much, Dayo. Thank you very much. It's good to be here.
My guest, Dr. Linda Anucha Dublin-Green, is a hematologist and with the Rivers State University Teaching Hospital. She's also head of department at the Rivers State University. Doc, great to have you once again. And for the second week running, back to back, it was a hit back to back. Last time was a hit. We just had to have you here again.
So maybe we should have a hat trick. I think there's something like that.
Sounds good. Sounds good. If you're game, I'm game. And remarkably, the very last episode had to do with blood as well.
Yes.
It was what Blood Donor did.
Yes.
That was the theme of that conversation.
Yes.
And we're discussing a somewhat different matter, but very much blood related as well. Now, it's your field. So is it happenstance or is it deliberate that World Blood Donor Day and World Sickle Cell Awareness Day is the same week or the same month or thereabouts?
I don't know how they came about, but I think it's just coincidence. I don't know. I mean, they may have their reasons, but sincerely, I really don't know why they're back to back.
But from your experience and in your opinion, do you think there's some significance to that or relevance to it?
Yes, I think there is because so you're just making the week before we came to tell people, about the reason why you should donate blood, why it's important that you voluntarily come and donate blood. And I think the major users of blood are the patients with sickle cell. So you have come to tell them, oh, please come and donate. And the next week you're coming to tell them, these people really need it. So it has a way of hitting hard or taking the message home. Like we have users, and these people or these sets of people are one of the users of this blood that we asked you to donate the other day. So there's this awareness. So everybody is aware that this is like a blood month.
So talking about taking the message home,
yes.
let's get to the message then. What is sickle cell and how does it affect the body?
Okay. So sickle cell is the most common inherited blood disorder. Okay, where that affects the hemoglobin, which is the protein in the red cell that carries oxygen around the body. So normally, this hemoglobin is disc-shaped, as in a normal hemoglobin type. But for these people that have sickle cell, it's like crescent-shaped or S-shaped. because there's a genetic mutation that has led to this. So because of this, those sickled cells cannot pass through all the vessels in the blood, or in the body, especially the very tiny vessels, we call them capillaries and all of that. So they get stuck there and then bring about the complications or the symptoms that we find them exhibit, that's the sickle cell patients. So there's a genetic mutation that occurs in these individuals.
What causes this genetic mutation? Do we know?
Well, so a mutation is a mutation. Something happens, and a mutation just means something is normal and all of a sudden there's a change. Okay, but it's been said that those of us in sub-Saharan Africa, we are the highest, we have the highest burden of this of the sickle cell disease. And so when you go back history, it said that patients that have, or people that have HBS, which is what we call it, HBS gene, they tend to have, they are protected, let me use that word, or they less susceptible to malaria, which is endemic in this area or in this region. So, and we know the effect of malaria. You can imagine those other years when advances are not like it is today, medications are not like it is today. So those days is said that people with HBS tend to, of course, so malaria, people with HBS manage it better. It doesn't really affect them like it affects those with the normal AA genotype. So over time, people with that HBS tend to, they lived longer, they lived more because the malaria was killing people then. So people that had that gene lived longer and, so they mated more and then brought about what we call it suffering today. However, it takes two individuals to give rise to HBSS or HBSC or SD, or that's the sickle cell disease. That is to say, a parent will be HBAS, that's the trait. Another parent will be HBAS. So the mother is AS, the father is AS. And then so when there's this fusion or there's this coming together of the S gene of both parents, it gives rise to SS. That's for the homozygous SS. But one parent can be AS, the other parent can be AC. So they have different hemoglobin genes or types. It can be C, it can be D, it can be E, it can be O. So it depends on, it can be beta thalassemia. So it depends on what I'm saying in general, it takes two to form this.
Okay. Now, just for some clarity.
Yes.
Because you've spoken a lot of medical, pardon the expression, jargon right now.
Okay.
So are you referring to genotype, or are you, when you say AS and you mentioned AA earlier on, are you referring to genotype or are you referring to something else?
Yes, genotype.
Okay.
Yes.
Well, you were mentioning C and things like that. I thought genotype was just AA, AS, SS.
We have others, SC.
Oh, okay.
We have SD, SE, SO, S-star. So there are other. So that's why it's called a disease.
Okay.
It's the umbrella body or a bigger body. So when we say sickle cell disease, it's different from sickle cell anemia, which is the homozygous type, which is the HBSS. Okay. So, but these other ones are also called disease, the SC, the S-star, even the AS is a trait, so it's also part of it.
Okay, now, since we know what causes it, I think this might come up later on, but we're there already anyway, okay. So let's just go with the flow.
Yeah.
Now, since we know, as you said, there's two people who come together, and then they form this, and once there's that S in their genotype, there is an inevitability, am I right, that they're going to produce a sickle cell child. Is it inevitable?
No,
that.
It's not.
Okay.
Yeah, so it follows the Mendelian law. I will still always come back to Mendelian law, where there's a 25% chance for every pregnancy. There's a 25% chance of having SS. For every pregnancy, there's a 25% chance of having having AA. then 50% chance of having AS. So it depends on the one that is being expressed.
Okay. Once again, as I was trying to say earlier on, so since we know this, and I'd like to presume that most people at least know this, or maybe they don't, that's why where we have a problem. But since we know the information is commonplace, it's in the public domain,
Yes.
why are we still producing sickle cell human beings?
To be honest with you, Dayo, it pains me that in this 21st century, we are still producing SS or sickle cell disease. However, it's usually love. But I always tell them, you have not seen a patient or you've not suffered from it. If you suffer from it, you realize that there's nothing like love. Awareness is very important. Misdiagnosis is very important because some people will tell you, oh, I did my genotype. It was AA they gave me. The other partner will say, I did mine, I was AS. There's always one person that will agree that he or she is AS. But at the end of the day, they're giving birth to SS or SC or the other. So what's the problem? And that's why we have moved our diagnostic tool to something more, the gold standard anyway. All right, so sometimes, like I said, awareness, misdiagnosis. People also don't believe there's anything like that, unfortunately. And they will tell you it's Obanje and co and all of that. So it still makes us produce sickle cell disease patients, children, or whatever in this 21st century. It's really painful.
I use the word Obanje now. I think these are some of the misconceptions of it. We'll come to misconceptions later as well in the course of this conversation. But you inferred just now that, some say it's love, so they damn the consequences. And you said that there's nothing like love, or love shouldn't play a role
at all
in this matter. So speaking of consequences, what are the consequences? Maybe they don't know. That's why they feel, it's all right. Because not many people in their lifetime are going to encounter a person who is sickle celled. Personally, I think I've only ever closely encountered one person and see the person go through a crisis. So what is the effect of sickle cell on the patient and even those around them? What's the impact? What happens?
Unfortunately, it affects not just the patient, but the caregivers and everybody, the family, even the community at large. It affects every part of the body, actually. And of course, there'll be, it can even lead to slow growth or retarded growth. Of course, there's stigmatization. So the patient is depressed, frequent visits to the hospital. You see them begin to abuse some drugs because they want to get relieved of their pain. And financial burden. The family will always be in the hospital. You sleep today, sometimes you have 2 or 3 in a family. So practically the parents are in the hospital. Even in the society, the person most times they can be less productive. So it impacts, and then what we call morbidity. Morbidity is incapability, or what will I use now? The patient is unable to do some things for himself or herself, or reach some goals or heights that normally you would have aspired to be. And ironically, they're very intelligent people. So, but because of the effects on the body, if our spirit, soul, and body, they tend not to do so to fulfill their desired, what will I call now? Help me out.
Goals in life?
Maybe, sometimes.
At the danger of sounding insensitive, how is this different from most of the families or the life of any average child, or even my childhood, for example? My genotype is AA. And by the way, I was tested many times.
Okay.
So I know. In fact, most times I forget my blood group, but I can't forget my genotype ever, because once again, I was tested so many times.
Okay.
And the reason I was tested so many times was my doctors were very concerned. Once again, my genotype is AA, but I took ill a lot. I've had my very fair share of hospitalizations, and drugs and injections and you name it. I had everything. Pneumonia, malaria was like me playing outside, and the rest of it. And things happen. Children have diseases. They fall sick. It happens. Some children more than others. I've stayed in hospital wards where other children died right next to me, sadly. I remember a boy with meningitis who died, other things. It happens. So how is this different? Because once again, children fall sick. It's a natural thing.
Thank you very much, because you are a typical example of the difference in their illness and yours. So remember I told you, they are susceptible to malaria. So malaria should be your friend. I mean, as a child, while growing, I also fell ill intermittently because I'm also AA. I've been tested severally, So, but after a while, I'm sure you don't go to the hospital all the time anymore.
No, I don't.
Fine. But theirs will progress because there will be end organ damage after a long time. Their spleen, they have what they call autosplenectomy. That's when we start talking about the symptoms, the effects, and all of that. And so they are susceptible to infections, which you are no longer susceptible to, and then you see them have nephropathy, their eyes affects, because I said it affects every part of the body. But like a child, legs, like every other child, you're sick, but after a while, you're fine. But theirs will linger and even get worse. But we're happy because we have some people that have lived up to 50, 60, 70 years, So, theirs is a lifelong thing. But for those of us who, like other children, after a while, sometimes it's exposure, maybe environment where they find themselves, and then infections. Children are bound to have infections, but after a while, they are fine. So they outgrow it. But this one, you really do not outgrow it.
Very often you hear the word crisis. It's a word closely associated with persons living with sickle cell.
Yes.
What does it mean for a sickle cell patient to have a crisis? What happens during that period? And how prevalent is it? How often does it occur?
Okay, they have different types of crisis. We have the painful crisis, the painful vaso-occlusive crisis, which is the commonest cause of crisis. You have the hemolytic crisis. You could have the aplastic. You could have, so you have those crises. And it's simple. The normal red cell will pass through any vessel in the body and pass their way. So they are malleable. They can bend and pass. But these sickled ones, when there's hypoxia, that's low oxygen tension, they become sickled. And so as they're trying to pass they can't even pass through those tiny vessels. So they all get stuck. They stick together and form like an S shape. So they prevent, when they go together, they cause what we call infarction. And once things stick together, they cause pain. So that's why we have frequent vaso-occlusive crisis. All right, they have pain, and then also they could leave the spleen. As they pass through the spleen, they could, because the spleen has a way of, we call it, one of the functions is red cell integrity. Any red cell that is not normal, as it's passing through the spleen takes it up, chops it off, engulfs it. It's like what we call reticular endothelial system. It engulfs it. Now imagine these sickled ones. Once they get there, it keeps engulfing. Okay, and which makes them to have anemia. One of the reasons why they have anemia, and over time too, because of that infarction. So after with the too many engulfments, let me use that word, or trapping, they have a fall in their hemoglobin concentration. So they have anemia. So that could be, and then as they're being engulfed, they keep hemolyzing, they keep breaking down. So that can cause what they call the hemolytic crisis. The other one, as they try to pass through those tiny vessels, they can't pass. They cause painful crisis. All right. Then you also have the aplastic crisis, where they could have an infection with, in fact, particularly parvovirus infection, and the bone marrow will just switch off and stop producing anything, and all their cell lines will just drop. So then acute chest syndrome too is a type of crisis where they have an infection and then infarction on the chest, and which is very lethal. It can be very lethal.
A part of the theme for this year's observation, the first part is transforming care. What does that mean for patients and even healthcare providers? Considering all the knowledge we know, we've had over time and experiences, what does transforming care mean in this context?
Okay, so when you talk about transforming care, so they want a transformation. So something is already up, but they want us to do better. I believe that's what they mean by transforming care. It's a global problem. So it affects people living worldwide, but it's predominant or prevalent here in sub-Saharan Africa and Nigeria, having the highest burden. In fact, as a matter of fact, about 150,000 children are born every year with sickle cell. That's a lot. Okay, so why, with all we are telling, of course, I want to believe there's awareness, but maybe we are not doing enough. So, but in this case, I always tell people it's a preventable disease. So we will not get tired of creating awareness. All right, that's one of the forms of even care. You must create awareness so you even prevent it from occurring. But however, over the years, things have changed, so it means we want to bring it home. We want to give people better care. We want to use the current methods of treatment or care to people even in the rural area. Some people cannot access healthcare. So we want to look for a way to transform, to make their lives better. They need to live better, because actually I don't like calling it a disease. I just want to call it a condition, because they were born with it.
Speaking of treatment, do we have any recent advancements in the treatment of sickle cell, and how accessible are they in Nigeria?
Well, yes, we do. In fact, most of our patients are doing better now, because we have outside the routine medication to give blood medicine, prevent malaria and all of that can bring down their immunity and then worsen their problem. So apart from all those routine medications we give to help forestall or prevent crisis, we still have disease modifiers like the hydroxyurea, which we incorporate in our management on patients we're managing for sickle cell disease. So this hydroxyurea, what it does is it helps to modify disease in a way that it increases a type of hemoglobin in the body, which is the fetal hemoglobin. The fetal hemoglobin is the hemoglobin that the child in the womb, possesses. That after that, when a child is born, you're born with some degree of it, but after 6 months, there's a switch to the adult hemoglobin. And that one hardly sickles the fetal hemoglobin. So now this drug is made to produce more of the fetal hemoglobin, thereby reducing the sickling, or the number of sickled hemoglobins in the body that the body is producing, and then reducing the crisis. So that's one major breakthrough, and that one is readily available, and I think to an extent affordable, but affordability depends on the individual. However, we have gene therapy, which they use the CRISPR. I would want to go into that, but gene therapy, and of course, bone marrow transplant, which gives it a cure.
There is a cure?
Yes.
Okay. On that note, let's take a break.
Okay.
Because I'm curious to find out. I did do some reading before this. I usually do before discussing any topic, and I came across this, and I'm quite curious to find out, because something this serious and genetic does have a cure. Because from my understanding, most mutation-related ailments or conditions or genetic don't have cures, but I read that this one does. But we'll find out more when we return from the break. It is Canvas in Niger-Delta Roundtable in commemoration of World Sickle Cell Awareness Day. We're discussing blood, sweat, and cells with hematologist Dr. Linda Anucha Dublin-Green. Stay with us. Be back in a bit.
In the heart of our journey, where the sun touches the earth and the wind whispers through the trees, a new chapter unfolds. A chapter where energy illuminates more than just bulbs. It lights up minds. A chapter of unity, a coming together with a common goal to energize futures and illuminating lives. In classrooms, young dreams evolve, inspired by the promise of a brighter tomorrow fueled by available energy. Small businesses flourish, becoming seeds of prosperity. Energy that empowers and is catalyst for growth and change. The future is energy. So, let's light up the path to a sustainable future together. Energy for you, me, and the world at large. Energy for people and planet. We are Renaissance.
Welcome back. Still converse the Niger-Delta Roundtable brought to you by Renaissance Africa Energy Company Limited. Thanks for staying tuned. I'm Dio. In commemoration of World Sickle Cell Awareness Day, we're discussing blood, sweat and cells with hematologist Dr. Linda Anucha Dublin-Green. Doc, you're welcome again. Thank you for your time.
Thank you.
Interestingly, before we went on the break, you mentioned that sickle cell has a cure. And even when I saw that, even before we started recording, when I was researching this topic, it struck me. I didn't know that before, actually. And you described sickle cell as a mutation.
Yes.
Now, I think cancer is also a mutation.
Yes.
But cancer doesn't have a cure, does it?
It does.
But cancer does too.
Yes.
There's so many things I don't know that.
Yes.
Okay, so what's the cure for sickle cell?
Okay, thank you, Dario. I mentioned stem cell transplant. So that's a cure. What happens? I know that's the next question. Okay, so we're going to take off your stem cell is what produces blood, produces your blood types and all of that. So what happens here is the patient will ablate the stem cell or the bone marrow, the cells in the bone marrow, and now get a matching donor for that person. So you should be HLA typed or matched typed. And the person's cell is infused into the marrow, and then the marrow starts producing that new cell. So if the bone marrow, so whatever cell is infused is what the bone marrow produces. And therefore, if you have given somebody an AA cell or stem cell, the marrow starts producing whatever you give to it. So it will stop producing the sickled forms.
Okay.
However, the gene is still there. I wouldn't want to go into genetics now. So I won't say, because I'm cured of it, I'll go ahead and marry an SS person. No, you may give birth to SS.
Okay, so can this cell, so this marrow cells, be taken from any other person, just anybody, and then given to? No,
it has to be matched. I said HLA matched, so it has to be the same type. My body will recognize it and accept it.
Okay, so what's the problem then? Anybody can marry anybody, give birth to whoever, and then there's treatment for it.
But it's expensive. Expensive.
How expensive? You don't have to give exact figures, but
it runs in millions, actually.
Oh.
Yes. And, not too many centers here in Nigeria do that. But I know we have a center in Benin. I think we have in Lagos. In fact, I just saw one that they just launched or something, a center, something African, something. A big hospital in Abuja.
Okay, I'm playing devil's advocate here. So, what if I know I got money, or we're loaded, myself and my wife-to-be, or a woman and a husband-to-be, and they know that money is not an issue. Okay, we got tested before we got married. I'm AS, you're AS, or one of us is even SS. I watched that podcast that day on Canvas, the Niger-Delta Roundtable, where a certain Dr. Dublin-Green informed that there's actually treatment for this. We're just talking money here.
Yes.
That's all. Money is the factor.
Yes.
We got money. So baby, let's go ahead and get this thing tied up. And if we produce a sickle cell child eventually, not to worry, we'll just throw some cash at it.
Okay, but everything has pros and cons. And I mean, why should I even want to do that? Dio. It's a preventable disease. Oh, sorry, not a disease, like I said. It's a preventable condition. Before you even get to the point of doing a stem cell transplant and all of that, a child can, as early as 6 months, begin to express the symptoms. And that's the earliest symptom is hand and foot syndrome. Where the hands become swollen at 6 months. Remember, I told you there will be a switch at 6 months. So once that switch occurs, the sickled forms pour out, and then the child can have that hand and foot syndrome. You will go to the hospital. You will stay in the hospital. Okay, you wouldn't want to watch your child being in pain because you can cure it later, because you wouldn't want to do it. I don't think you would do it at 6 months.
Why can't we do it at 6 months?
Well, of course, the procedure, it takes a lot. It's not so easy. It takes a lot, and so the child may find it a bit difficult to take it at that early age. So at least the child should get to maybe 2 years before you think of the transplant. The child can come down with stroke. That's the commonest cause of stroke in children. There's a child I saw yesterday. He's had like 3 episodes of strokes. He's just 7 years. So why do you want to pass through that? Besides, you want to use your money for something else. So I can bet you that now you can even do prenatal diagnosis. So yes, you can have, baby, we have the money, let's go. And before, while your wife is pregnant, you can test whether this child has, will come out as a sickle cell disease patient or not. So if you test it and it is positive, why let it come out? I don't want to go into why let it come out. But you can make a diagnosis before the child is born.
Mm. Is diagnosis a problem? Because with most illnesses... Okay, let me ask the question.
Okay.
Then I want to ask something else. We'll come back to the question.
But did I answer your question?
Yes, you did, actually.
All right.
Yeah. Is early diagnosis an issue? Because I know with those in the medical field, for every ailment or condition, early diagnosis is key.
Yes.
Because something that, even an ailment that could be considered trivial, could still kill you.
Yes.
If it's not diagnosed early enough.
Yes, like
detected
malaria.
early.
Yes.
Exactly. So, is early diagnosis an issue? And why is that so? And how can that be addressed? But before you answer that, let's go back to the comments you made. And it's seemingly unrelated subject matter, but to my benefit, and I perceive at least one other person might learn something new here. You mentioned that cancer also has a cure. I was of the opinion that it didn't. Yes, you can conduct surgery, you can cut certain parts out, you can apply certain treatments, you hear the person has gone into remission,
yes,
and then it returns again, and all that. So what is the cure in it?
No, some of them, when you do it, it's still this transplant. When you do a transplant, it may not reoccur. In fact, they were trying to treat, how did they even know stem cell transplant can cure sickle cell? A sickle cell patient had leukemia, which is cancer of the white cell. So they planned transplant for that leukemia. When they did the transplant for the leukemia, the phenotype changed and the sickle cell disappeared. Mm. So some illnesses, some cancers, actually when you do a transplant, it may not reoccur. It may not reoccur. In my word, it may not reoccur.
Okay.
So when it doesn't reoccur, of course, it's a treatment, it's a cure. Mm-hmm.
But do we have a definitive, absolutely certain cure for cancer?
That's what I'm just told you.
Okay, let me rephrase that. For all cancers?
No, maybe not all cancers.
Okay.
No, maybe not all cancers. Okay. Maybe not all cancers.
Okay. So all right. So moving on then to the question I asked. Early diagnosis. Do we have a challenge with that, and how do we address that?
Well, in this part of the world, early diagnosis is a problem. A child, what are the symptoms now? It's just like normal malaria. So every time we treat malaria, and children, like you said, as a child, you were sick. So I'm sure they would have been treating malaria back to back. So they They don't even come to the hospital early. Sometimes they don't even know the symptoms to look out for. I just mentioned hand and foot syndrome. Okay, so a mother may not even know that if you see a child at 6 months, 7 months, 8 months, the hands are swollen, the limbs are swollen, it's almost always sickle cell. So, but they don't know. They may not know. They may just think, massage and all of that. Sometimes they just go to the chemist or whatever. They go herbal and so on and so forth. They even assume that children are bound to be sick. So they don't even come early to the hospital. So that's one part of early diagnosis. We have a problem. And then all hospitals should be able to manage patients that have that illness or disease. So the problem is most times we don't even come to the hospital early. Facilities where early diagnosis come. Now we even do neonatal screening. We want to start neonatal screening in my hospital. Any moment from now we'll kick off. So once a child is born, you screen.
Yeah.
So once you screen, you know whether you can start management early enough to prevent some of these complications and to advise the patients better on options that they can use.
When you used the word chemist earlier on, you had this look on your face like you don't like chemists.
No, they are supposed to be dispensers, so they're supposed to just dispense drugs. But people tend to have confidence in them because I guess they appear to be cheaper and then they're in your locality. And then so you even hear them calling them doctors and all of that, But in the long run, you will spend more money going there because when you have spent and they have done what they think they know how to do, you'll say, come back to the hospital. And then, if not even with more problem.
The second part of this year's theme is strengthening communities. Let's talk about that for a bit. As far as communities go, what roles do family, or the loved ones, caregivers, schools, every individual and sect that makes up communities, what roles do they play in the life of a person who has the sickle cell condition, and how can the community be further strengthened to deal or help manage the condition?
Okay, so let's start from the smallest unit, which is the family. The family should be aware of the condition, understand the condition, and know that there is support system for this individual. Remember I mentioned the Banji. So in those days, you could have a family lose all their children, to sickle cell. I know someone may give a testimony. He's the only survivor or child of that family, and he too is I think SS, but he survived, or ES I think, I can't remember. So the family must understand that it's a genetic problem. Please, it's not the mother's fault. Because sometimes, as I said, love does not count here. Because when they say, I had a patient, she has 3 children, 3 of them are sickle cell, have sickle cell disease. In fact, sickle cell anemia, that's the homozygous form, which is the most severe form. That's HBSS. Okay? And the husband left. The love cleared because of the frequent visits and every time they're in the hospital. So the family should understand that, well, I think I want to say you people should accept, husband and wife, that it's your fault. But maybe too, it's not your fault. Maybe you thought you were AA and the other person results showed and all of that. So first of all, strengthening the community starts from the family. You must encourage your child, or if you're a caregiver, you must encourage. You shouldn't be tired. You should readily seek for help, medical care. Don't think, sometimes when people do something over and over, they think they know it all. So you want to treat because you already know what the doctors will give, or you just run to the pharmacy. You must seek health care in the right place as a family. Now, so we go to the community. The community, it's extended family, brothers, sisters, aunties, and then wherever you find yourself. These people should not be stigmatized. These people should be shown love. And, communities should be able to also create awareness. Community, okay, so you can have the churches, they are all in a community. So awareness is very key. And if possible, have let's say hospitals or centers where these people can easily get care from. All right. Now, even in schools, they should not be stigmatized. You should know a child that is sickle cell in a school. You should know. So you should know that this child does not need stress, because one of their problems or one of the reasons why they have crisis is stress. It's stress related. So they should relieve them from of some of these strenuous exercises or duties and all of that. And if a child comes to you to say, I'm sick, please don't tell this child, why are you always sick? Don't make the child look, don't worsen the problem, that the child has. So as a school, you must be sensitive. You must have sick bays. So if there's any little pain, we should treat their pain as important as any other illness. So any little pain, you should readily say, take the child to the sick bay and all of that. So you must be aware. And then also you must talk to create awareness, even in your devotions, and allow experts to come and talk to your students, because the pupils must be aware. Because I believe that people tend to grasp or keep in memory what they learn in school. So if these schools these people are taught that AS, you don't marry AS, make them understand the impact. I don't think they will come out from school and be looking for AS to get married to. All right. And then which other is it the NGOs and all of that? They should all come. Government also should help make policies that can help people. I don't know if you're going there. I don't know if that's a question, but
no, you can answer it now.
Yes. So they should make this their care affordable, if possible, free medical care for these people. Because with repeated hospital visits, they tend to run out of funds at times. They need more attention. So there should be hospitals in these localities where people can easily access healthcare. Policies, subsidize their medication, even if you don't want to do free care. Sometimes, why should these people pay for routine medication? Simple things like folic acid and all of that. If they have, and so for those of them that come to our hematology clinic, for every clinic visit, you must do your full blood count. We want to know your blood level. So maybe you subsidize all of this for these people so that they can, afford it. And most importantly, health education. It's a preventable disease or illness or condition. Why do we still have it in 2021? 21st century, sorry.
Should parents or guardians or other loved ones associated with a person living with SCD, should they resign themselves to the possibility or the chance that we're going to lose the person?
I always tell people that healing comes from the mind. So you must be optimistic about everything in life. You must have a positive outlook. So I would not want any parents to feel that way. Remember, I said we've had people that have lived. I have patients that have sickle cell, that are married, they have children. They are living their normal lives. So I don't think anybody should give up on anyone.
Sometimes, even with the best of care, we still lose them.
We can lose anybody, even with the best of care. But we will do our bit. So it's not good. I don't think I would want any parent to give up, because the moment you give up, then you've lost the battle. We call them warriors, sickle cell warriors, because we know they fight, and they fight very well. And a warrior wins the fight. So that's what we call them, sickle cell warriors.
Now, misconceptions. I know you mentioned the Ogbanje thing repeatedly, but what are some of the more common misconceptions surrounding sickle cell, and how do we address this misinformation or this ignorance, as it were?
Well, I think the commonest one is, I want to say that stigmatization is a misconception. We shouldn't stigmatize them. It's not their fault. Okay? They may grow smaller than they should, don't see them as less of a human. It's not their fault. Like I said, they're not a bunch. People should come out and accept that. I call it's even a menace in our society. Yes, so people, or maybe I should not use that word, but it's painful. I don't know how to explain. I don't know how to express it. It's there with us. We are the highest carriers or whatever it is. So it's a disease condition. It's not family. Nobody's fighting you or after you, because most times they relate that, maybe they want to wipe out a family. No.
It's not village people. It's
not village people, thank you. And it's not the woman's fault, please. It's not an X-linked disease. I know you want to go into that.
No, I'm not going to go into that.
But so in talking about awareness, okay, so I'm here because, of course, the Medical Women Association of Nigeria. Yeah, so we create awareness and try to reach out to communities and, give as much care, we can. So our theme, our mantra is healing with the love of a mother. So of course, how a mother will not want to watch a child die in pain. If you take statistics of caregivers in the hospital, they are mostly mothers, women. So that's why we are advocating in the Nigerian Medical Women Association of Nigeria. We are advocating, creating awareness, trying to see how much we can help, to curb this problem that we have faced with.
I'm curious. This wasn't one of the questions I had pre-planned, but you've mentioned more than once that, Sub-Saharan Africa has the highest number. Nigeria has, the highest. Why is that the case? So my conversation so far, I'm tending to think more that it's because people just act in ignorance and say, we're going to go with love. Maybe they watch too many Nollywood movies and they feel, let's just go ahead. Is that it? Or are there other environmental factors that lead to such high numbers in Nigeria? Okay,
first of all, I told you how we have it in Sub-Saharan Africa because of the malaria endemicity in Sub-Saharan Africa. So which has made people with that trait to live longer or to be able to, they tend to manage it better, malaria infection better, which over time led to this. And we are more in number. So they say the more the merrier. This one is the more the more.
Okay, our large population.
Yes, our population. Yes. So of course we are more, and then like you said, people awareness too plays a major role, and I think that's why we have more of this disease in Nigeria. In Nigeria. Yes.
But I've known this since I was a kid.
And let me tell you something. Okay, even diagnosis, making genotype testing, something as simple, as cheap, as basic as genotype testing, most people don't even do. Sometimes even when they go, remember I said, they could be misdiagnosed or they give them a wrong report.
All right, we're wrapping this up shortly. I was going to ask what your messaging would be to the government as regards policies, but that's been addressed already.
So let me cut you.
Okay, that's fine.
So now we have better testing method for genotypes. For genotype, to test your genotype. We have now gone ahead to doing the high performance liquid chromatography, which is the gold standard for genotyping. Okay, so the machine you pass the blood in the machine just reads it and shows all the different types of hemoglobin you have in your body. Before now, the normal or the electrophoretic type is you look at it and look at how the bands are moving and know, oh, okay, this band has moved here, it's AA. Oh, no, this band has moved here, it's AS, and all of that. So sometimes you could have observer error, which is why, and then, you could have this, I tested AA before, why am I testing AS? So I tested AS, all of that, which is one of the major reasons why we have this, this burden of sickle cell in Nigeria. But we are trying to say, no, let's go further, do this testing. And when we tell you you are AA, then you are AA. Because we have seen all your genotype displayed on the machine. And so it's accurate. And that's what they use everywhere in the world. And we have it available in Rivers State. And like I will always say, also in the Rivers State University Teaching Hospital, we have it.
Of course.
So we are now making it for everybody that if you want to check your genotype, which this is a message I want to send to, I wish the government can even do that, make it available. Something as basic as that available, especially in the teaching hospitals, in the general hospitals, even in the health centers, so that when people go there, because that's where people, that's their first port of call. That's where they go. The health centers are more in the community. So they should be able to test for their genotype using that machine. And I think it will help a lot. It will go a very long way to preventing more of this in the future.
Thank you for that. I thought we were done with messaging to the government and policymakers, but you added a lot more significantly. But finally, what's your message to those living with sickle cell disease and their loved ones?
For those of us living with sickle cell disease, you are not less of a human. You are a warrior. I don't want you to blame yourself for anything, because sometimes they do. I don't want you to blame yourself for anything. It's an inherited disorder or condition. And the only thing I will say is make sure you get health in an appropriate place. Be quick to let us know that you're having pain. When you're having pain, please come to the hospital. When you're having dizziness, please come to the hospital. When your body changes for any reason, please come to the hospital. What am I saying? They should just seek help or, come to the hospital as early as possible. And then they should also help us to spread the news. They should help us to create awareness. They should refuse to be stigmatized. That's for the patient now. Refuse to be stigmatized. Come out and tell people what your condition is. It will go a long way to, helping people prevent, because nobody wants to see someone that is sick and want to say, I don't care. I don't care whether my child comes out like this as an individual. If you know the impact it has on these people, then you want to prevent it further. And then I also want to encourage the caregivers and appreciate them for what they're doing. It's not easy. If you have one of them, you will know what I'm talking about. So we appreciate what you're doing for our patients, and want to encourage you to even do more. And we are hoping that we'll have a society where their care will be free. They can have access health anytime, any day. So we call you warriors, and we know you will always win.
Thank you.
Yes.
And that's it. That's a wrap for this episode of Canvas, the Niger-Delta Roundtable, commemoration of World Sickle Cell Awareness Day. We'll discuss blood, cells, and sweat with my guest, hematologist, Dr. Linda Anucha Dublin-Green. Thank you so much. It's been a hit back-to-back. Who knows? Maybe we'll make it a hat-trick. Thank you for your time.
Thank you so much, Dayo, and I hope your organization, I know they do a lot. Now, this one is for your organization. I know they do a lot. But I know they can also help in procuring this basic testing method. We appreciate them. I know it's not one. I'm sure they're about 4 hefty people. I know it doesn't mean anything to them, so they can afford it and strengthen the healthcare system.
I know that our leadership, they watch this and they're listening, and like you rightly said, we're doing a lot already in the health space, and I'm sure that there are possibly plans even to do a lot more.
Yes, and let me just say that I know they do outreaches a lot. So what I always preach to people now is when you want to do an outreach, please, let's test people with the better option. So that when we tell them in the community you are AA, then you are AA. Right. Because the other type may not tell you that you're A-tar, beta tar, or AC, or the other way. I know Dayo wants to go, but I must tell you with this message.
No. We appreciate the message, and
Thank you.
we definitely will take it in stride. And I'm sure once again that our leadership will consider and do everything possible to ensure we can improve the quality of life of our people in the Niger-Delta and by extension even Nigeria as well.
Yes. Thank you so much, Dayo.
Thank you again, Dr. Linda Anucha Dublin-Green.
Thank you so much.
And thank you for joining us in this episode of Canvas and Niger-Delta Roundtable, brought to you by Renaissance Africa Energy Company Limited. Our sickle cell warriors wish you the very best. I'm Adedayo Lushakin. Bye for now.